present presentation?
Yes, we'll come here, and I'll sit there.
Okay, thank you.
Yes.
Thank you.
Okay, good morning, everybody. Welcome to this session on health programs for men, which is really, of course, critical considering what the symposium is about. We have 3 speakers for this panel, and we're very lucky that they're all here. And the main theme of our panel is, like I've said, health programs for men. And we know that health programs have traditionally targeted women, and this usually results in making invisible men's health needs, including sexual and reproductive health and emotional health. But a health program for men needs to include strategies for addressing patriarchal value systems. This panel presents research to identify priority areas and policy implementation experiences of reaching appropriate health services to men. So I am going to start by introducing the person that has come the farthest, and that person is Daniel Costa Lima. Daniel is an author, the author of this presentation, and he is a psychologist with a master's degree in public health. He has been working with the NGO Institute, he will tell us himself, in Brazil on issues of gender and masculinity since 1999. Please welcome Daniel.
So good morning to you all. It's great to be here. It's the second time I've had the pleasure to be in India. I was here like 10 years ago, to the south of India, working on a different project with different issues. So it's pretty interesting to be back here. So this policy that I'm going to be talking about, the Brazilian National Policy of Integral Health Attention to Men. First of all, I think it's really interesting to say that in a country that is so sexist as Brazil, in a country that has its culture so much rooted in patriarchal values and in machismo, it's pretty interesting to have this policy, to have a policy working towards men's health with a gender perspective, also trying to improve women's and children's health by targeting men's health. And I've been working with these issues since 1999 when I started an internship at Instituto Papai, which is a feminist NGO in my hometown of Recife. And Jorge Lira, he's the founder of Instituto Papai. He's actually on the room over there right now doing a presentation on fatherhood, which is the main issue of Instituto Papai. Papai means daddy in Portuguese. And after working at Papai for many years, I also worked in different projects for Instituto Promundo. And after working for almost 10 years inside for the civil society, since the last year I've been working for the Brazilian Ministry of Health. So the idea, the important thing to keep in mind, the interesting thing to keep in mind is that all these issues that were only at first dealt by the civil society organizations, now the Brazilian government is also really took on the role of actually talking about gender relations, of engaging men to end violence against women, to engage men in positive fatherhood. So this is really interesting to see how this movement that started in the NGO sector is also now happening in the government. So I'll try to quickly present what we've been doing with this policy in Brazil. So at first I have to explain a little bit of the Brazilian national system, which is called SUS. We've had this system since 1988. It proclaims health as a citizen's right to be provided free of charge according to the principles of integrity, universality, equity, and decentralization. And the decentralization part is really important because we're talking about a really huge country. So it's not the government actually organizes some of the actions and transfers money to the states, and the state transfers money to the municipalities, and they are responsible for many of the actions developed by this national system. And SUS provides full health attention to almost 80% of Brazilians and has primary health care as its biggest initiative, and the family health program as its main pillar of action. Just to show you, we have many different health policies that target specific populations in Brazil. So since 1984, Brazil has had a specific health policy for women of all ages and for children. In 1988, as I just said, SUS was launched. In 1989, we had this policy towards adolescents. In 1994, that's when we had our family health program initiated. In 1999, we had a specific policy for the elderly and for people with disabilities. And only in 2009, this policy, the Brazilian National Policy for Integral Health Attention to Men, started. So you can see that from 1984 to 2009, it's a long time. So you see that really adult men especially have never actually been the targets of most of the actions that have been developed by the public health system in Brazil, or I presume anywhere in the world. But it seems like a long time. It is a long time, but at the same time, this is really positive because Brazil right now, I think it's Brazil, Ireland, and Australia are the only countries in the world that actually have a policy that targets men's health inside the health system. So this is something really new. So for, as I was saying, for a country like Brazil to have this, it's pretty interesting, and I think it's a big achievement in itself. So as I was saying, this policy was launched in 2009, and the important thing is that it was written in a joint effort by the Ministry of Health, by different civil society institutions like Promundo, like Papai. They were actually involved in writing the policy, which I have right here. So you have a little booklet that explains the policy, which is quite extensive, and all this was written with these different partners from different researchers, academic experts, but medical associations also. So everyone got together to write this policy. So it's not just a policy that was written by the government or written by medical associations. And the things that the policy acknowledges, the reason it was launched actually was that men usually access the health system through specialized and or emergency or urgent care, with illnesses already settled and evolving in an unsatisfactory way. This contributes to men's higher morbidity and mortality when compared to women, to increase mental and physical suffering to men and their families, because if you have someone in your family, a man in your family who is suffering, who has these really bad illnesses or something, the whole family is going to suffer together with that person. So. And also absenteeism from work and high cost to SUS. So actually, if men do not do not promote health, and they get sick and they have to go to the emergency room and they have to operate, do some surgery or something like that, the costs to the system are really, really high. So this is also something that the government was thinking, okay, we can do this, this is going to be good for everyone, and we're going to save money, which is also a big issue. As a conclusion, lots of suffering and illnesses could be avoided if men engaged in healthier lifestyles and attended primary health services regularly. So when we say that men have a higher morbidity and mortality rate, we're saying that in Brazil, for example, women live on average 7.5 years more than men. The global average is something like 4.4 years. In Brazil, it's 7.5. So it's even worse than the situation that we see in most of the countries. So we really have to see what is going on, what is happening, and why are men dying so early. So the main objective and pillars of this policy are: the main objective is to facilitate and expand men's access to quality health actions and services, recognizing and effectively using gender relations perspective in order to reduce morbidity and mortality and improve health condition and well-being to the adult male population. And these are the main pillars of the policy: access and embracement in primary health services, because these services, they have existed since SUS existed. But the thing is, they usually target women, especially pregnant women, and children. So men usually, adult men usually do not go to those places because they get there. Sometimes they don't feel welcome. Most of the place is sometimes it's even pink. It's funny how the stereotypes really you can really see the gender stereotypes inside the health system. And you have a bunch of posters over there inside this institution. Most of them target women, target pregnant women, target breast cancer. Nothing there appeals to men. So the idea is that we have to change that a bit so men will feel more welcome to be there. So sexual and reproductive rights is another pillar. Fatherhood and care is a really, really important pillar of our work. And Eduardo Chacora, who's the coordinator of the policy, is presenting the work that we are doing around fatherhood and care right next door, right now. So it's a shame that you guys won't be able to see that some other day, but we got the same time slot. So prevention of violence and accidents is another really important issue, and prevention of prevalent diseases to the male population. So this, I usually show this, and this makes sense and really appeals to people in a lot of places, but when we're talking in India, it doesn't make such a statement, because usually when we talk of a population of 202 million people, that's a lot, but when we compare it to India, it's not that much. So our target population is men from 20 to 59 years old, because, as I said, there is already a specific policy to the elders, and there's a policy to adolescents, to teenagers. So, but that's almost 55 million men in Brazil. That's 27% of the total population of the country. And you see that the male population in Brazil is quite smaller than the female population. And that's because of all these men that are dying of a young age. So we have 99 million men and 104 million women in Brazil right now. And that gap is actually increasing every year. So this is, I think, it's nice to illustrate where is the importance of having a policy directed to adult men. So this is the mortality rate distribution in Brazil. So you can see that the blue are men and the red are women. You can see that from 0 to 1 years old, all the way up to 70 to 79 years old, men are dying more than women. Women die more than men after the age of 80 because most men have died already. So, of course. So, but the thing to keep in mind is what happens during adolescence. What happens when 15 strikes? When these boys become young men. So that's when we get traffic accidents. That's when we get suicides. That's when we get mostly homicides also. And the numbers in Brazil are quite striking. We have on average 50,000 homicides per year in Brazil. 50,000 homicides. No country in the world has as much homicides as Brazil right now. We have almost 60,000 deaths by car accidents in Brazil per year. And most of those, as I'm going to show, are men that are dying of those things. So we have 92% of homicides male are men who are dying of homicide in 92% of the cases. 78% of suicides men also, in 85% of deaths by car accidents. And seeing that, Deslandes, which she's a researcher from the University of São Paulo, she says that it's astounding to realize that the potential years of life saved by biomedical advances with an excellent immunization coverage, with a reduction of child mortality rates, among other public health achievements, can be taken away by the phenomenon of violence. And this is really what's happening in Brazil right now. So we do we have a huge effort inside the government to save the life of the newborn babies. And actually Brazil are really doing a great job at that. The child mortality rates are really dropping. So that's really great. But the question that I always have in mind is, why do we worry so much about the life of these babies that were just born? And it seems like when these babies turn into young men, we can just dismiss them. We don't worry about these young men anymore. So is the value of life higher at some point in the person's life, at some point in the cycle of life? So we have to do all those things to avoid children from dying and newborns from dying, but we also have to do the same effort to keep these young men from dying, and we're not doing that so far. So some of the activities that we're doing around this policy. First of all, we are doing a lot of policy making and advocacy towards men's health and gender equity in different governmental levels. So first of all, we have to sensitize, and this might seem a little strange, but all the time you have to sensitize the personnel and the public makers, the policy makers inside the Ministry of Health, because we are a very young policy. We have people inside the policy, inside the government, that still to this day really don't know that the policy exists. So the policy is implemented, is launched, but to be implemented is a different thing. We are implementing the policy still, and for that we have to keep close contact and actually explain the policy to every different branches in the Brazilian government, and we do that every day, basically. So we do a lot of trainings because of that, present or online education and campaigns to health policymakers throughout the country and to health professionals throughout the countries on the policy's 5 pillars. So we really, most of the job that I do at the government is to really travel around the country. I've traveled around the country many times since I've been there, like in the government for the past year and a half. I don't think I've ever traveled so much in my whole life. So, but we have to go to all this, to travel around this huge country to show people, to talk to people about this policy, to sensitize people about the importance of engaging men, especially young men, in health issues. We are doing a lot of sensitization campaigns to get men involved with care, health, fatherhood, gender equity, and nonviolent behavior. We're also doing a lot of development, and we're actually right now developing and implementing a partners prenatal care, which is a strategy to engage men in all stages of the reproductive health cycle in pregnancy, and at the same time to inform and guide men towards healthier lifestyles, health promotion, and gender equity. So basically what happens is, when a woman goes to the health center to get a pregnancy test, so at that moment we tell these health professionals that they have to ask women to bring their partners. If they want to bring their partners, they should bring the partners to the next meeting when they will actually get the results of the test. So that men from the first step are there already and are really together with their partners. And the moment that man goes to the health clinic, the idea is that we can actually use that to explain him everything we have to explain about pregnancy and how important it is for him to really be a part of the whole process, but actually to get that and to run some tests with that person, to run some exams with him, to talk about his health, because most of these men, some of them have never been to the doctor since they haven't been to the doctor since they were a young kid. So some of them have not been to the doctor for 10 years or 15 years. So we actually use that moment, and they are inside the health facility already, and we start talking to them about health issues. And also we're taking health actions to where men are. For example, we're doing a lot of interventions with truck drivers, a lot of interventions with port workers. So we're trying to figure out different institutions that gather lots of men as the workers, and we're going there and taking health information and gender equality information to those places, since some men do not like to go to the health institutions. So some challenges that we have been facing to implement the policy. First of all, the health services, be them public or private, doesn't matter, are still very much centered around a biomedical perspective. So every time we try to talk about gender and fatherhood and violence, they're like, well, what are you talking about? I'm a doctor. I kill people. I give them drugs so that they can get better. They come in and they go out. I don't have time to be talking to them, to be talking about gender relations, to see how things are going at their house and their life, how they feel as a man, if they're feeling insecure for something. And gender, well, what is gender? Gender is something for women, not for men. So there's still we still have a really hard time in trying to overcome this biomedical perspective barrier that really exists inside the system. Also, we suffer a constant pressure by medical associations to reduce men's health to their reproductive system, and mainly, especially, to the issue of prostate cancer. So we're talking about that we have to have a systemic view on men's health, and they say men is all about the prostate. Men is all about prostate cancer. And we have this whole Movember movement that started in Australia, and I think it could be interesting. But what is happening in Brazil right now on Movember, it really has been tough for us because it has really grown as a really huge campaign, okay. And we've been really pressured to reduce everything that we do to prostate cancer, and we know that there's so much more important issues when we're talking about men's health than prostate cancer, which becomes an important issue, especially when these men are over 65, and our policy goes all the way up to 59. So we don't even get there to 65 when prostate cancer really becomes a huge issue. So that's also difficult. And also, despite all evidences, health professionals and policymakers are still reluctant to draw strategies and work with the prevention of violence and accidents. So as much as we know the impact, the morbidity and mortality impact that brings on, especially to men, is still difficult to get that really going inside the Ministry of Health. People are still like, okay, this is the police's problem, this is a problem for the Ministry of Security, not for the health professionals. What can we do about that? So we're really still struggling to get that issue going inside the Ministry of Health. And also low funding. So we still do not have a budget that we can really send to all the 5,500 cities in Brazil so that they can implement simple action towards men's health. So for you to just have an idea, I think our funding last year was something around 4 million. And when you think about there are programs inside the women's health, inside the Ministry of Health, small programs that have 10 times as money. Just one program, not the whole thing. The whole thing, it has something like $1 billion a year or something. So it's not saying that we should take away from women and the money that the ministry sends to women's health. It has to increase, but also the money sent to men's health also has to increase a bit so that we can really take on and do this all over the country. And just to end, some successes and lessons that we've learned from these 5 years that the policy has been happening. First of all, fatherhood as a positive entrance door to men's health. So we've been really successful in using fatherhood as a strategy and opportunity to really introduce men to primary health services in the health arena in general, and to gender equity. So that's I think quickly fatherhood became the main theme inside the policy, really quickly. And also partnering with civil society organizations, with UN institutions, and with other health coordination, especially women's health, and with university and research institutes strengthens everyone's work. So when we talk about scaling up our actions, everything that we do basically inside the ministry is with these partners. And I believe that when we do that, everyone strengthens, get their works strengthened. So that's pretty interesting. We've had the policy implemented in all 27 Brazilian states, and so far in something around 800 cities, which for 5 years I think it's quite an achievement. We have had really recently the embracement of the policies platform by the communication department of the Ministry of Health. At first it was really tough. I mean, we really had to call them every day to try to get like one little spot, one little information inside the web page of the Ministry of Health. And now what happened is that they call us every time to ask, do you have something else for us to post on Facebook? Do you have any other information? Because what they realized is, especially with the issue of fatherhood, people are really catching into it. And are really on Facebook, they said that some of the posts that we had on fatherhood have been shared by like 2 million people, have been viewed by 2 million people, which is way more than most of the other issues that are being taught, that are being passed on by the Ministry of Health. So that's pretty interesting. Also, we are really sure right now that family health initiatives will only work if adult men are involved. When men are healthy, there's a better chance that women and children will also be healthy. That might seem like, okay, that's a given. We know that. But despite the fact that we have known that for so many years, not that many countries are actually doing that. So we really have to improve that. And despite this information that men's involvement is good for women's and children's health, we must learn, I think, how to direct our attention to men's specific health needs and really recognize their rights and clearly show that this is also positive to them. So we have to learn and improve our communication means of telling men, okay, not only this is good for your women, not only this is good for your partner and children, but this is good for you. I think we are there already at explaining how these actions are good for women and children, but we're not doing as good as a job to show men how much good this can bring to their lives, how much good a gender equitable society is good for men. Because if we don't learn how to do that, I think we get to a situation that we are asking men sometimes to give up some of their power and privileges, and we're not explaining to them that they will also gain something when they do that. Because no one usually wants to give up power and privileges. People who have power and privilege do not want to give those away. So we cannot ask men to give those power and privileges away if we're not able to explain them that this is actually going to be really good for them. So I think we really have to improve on that. So these are some of the contacts from the Ministry of Health, and this is like a poster that we've been running throughout the country, and basically says that we have to value affection and care that men have with their kids. And I gave some little pamphlets to you guys. It's all in Portuguese. I'm sorry, we don't have anything in English. It wouldn't make any sense to have them in English. But if you want to, I can translate them to you afterwards, or you guys can like use Google Translator or something. So thanks a lot. I'm sorry that I blew up the time a little.
Thank you, Daniel, for sharing your very comprehensive approach to men's health and gender equity. So now we are going to move on to Rajib Acharya from the Population Council. Dr. Rajib Acharya is a well-known demographer with more than 15 years of experience in academic research, planning, designing, managing, and monitoring large studies on population health and nutrition. He has authored several journal articles, book chapters, and scientific reports, and he serves as reviewer of several international journals. Please welcome Dr. Acharya.
Thank you. I don't know how did my presentation come to this session. It's not directly about programming on men. Okay? So it's a misfit, but I will try to show you some data and probably use them to program for men. Okay? So this is about a survey actually we did in Rajasthan state of India, and how over the years the scenario in premarital sexual experiences or romantic experiences change for the adolescents. We are going to discuss that today. Those who don't know about the first study, which was a subnational study of young people, first time done in India in 6 states, including in Rajasthan in 2006-07, and we had some funding later on to go back to the same primary sampling units and collect more data 5 years later and see the change that is happening over the years. So the main reason that we had this study was the need that we felt to establish the levels of key markers of life of adolescents over time, specifically to assess whether the situation on different transitions they make, like education, workforce, entry into sexual life, and so on, changes across successive cohorts. So drawing upon this data set from 2 surveys, quite large surveys, one is done in 2007, that used to be called Youth in India Situation and Needs 2007, and later on in 2012 Adolescent and Youth in Rajasthan 2012. We had money only for 1 state, so we only did it for Rajasthan. The other 5 states we didn't go back. So study, of course, were located in Rajasthan, in all the districts of Rajasthan, and we had about 147 primary sampling units, half of them from urban and half of them from rural. In each of the primary sampling unit, we prepare the list of adolescents and from using the house listing operation, and 12 to 20 unmarried adolescents, boys and girls, selected in each of these PSUs using systematic sampling. We only focused in the young age group of 15 to 19, and we interviewed actually boys and girls in separate primary sampling units, 76 PSUs for girls and 71 for boys. So in 2012, we had interviewed 1164 unmarried girls and 745 unmarried boys, age 15 to 19, and with response rate of more than 90%. This is about the second survey that we did. How did we measure sexual experiences? We probed different ways, but we probed in two different ways. One, using usual face-to-face interview, using a series of direct questions, and the second is through anonymous format, which was a sealed envelope that given at the end of the survey to tick across a response on a couple of questions that were asked. In the face-to-face interview, we probed both boys and girls in their sexual experience with a range of partners or situations. For example, romantic partners, the forced sex experiences with someone in exchange of money or favor, sex worker for boys with older married women for the boys only, casual partner for both boys and girls. We asked boys on perpetration of forced sex and probed on both lifetime and recent experiences on some of the indicators. In anonymous format, we actually asked two questions of everybody. Of girls, we had asked, have you ever had sex with anyone? And also, has anyone ever forced you to have sex? The boys, for the boys, the first question was the same. The second question was, have you ever forced any girl or woman to have sex with you? So these are the two anonymous questions we used a little differently for boys and girls. We know that sex is not reported very easily, particularly in a cultural setting that we have. So we had taken a lot of different measures to, reduce the underreporting of these experiences. We had several questions to arrive at a estimate on romantic relationship. For example, we had for the first survey, we had a huge qualitative, experiment to see what are the things that how they actually express their all these different experiences, and then use those in our survey. So, like whether we can directly ask whether they had a boyfriend or girlfriend. We asked them whether somebody proposed them, they accepted, like that, So whether they have spent time secretly with an opposite sex person, and then finally arrive at an estimate whether they had a boyfriend or a girlfriend. We asked about physical intimacy within romantic relationship on a continuum, so that they have opportunity to report gradually from hand holding to hugging to kissing to sex. So all these experiences in a continuum we asked. We separated questions on romantic sexual experience with romantic partner, with all other types of partners that you can think of. So that they have separate different opportunity to report on them. At the conclusion of the interview, as an opportunity given to report the sexual experiences and forced sex anonymously via sealed envelope technique that I said. We also trained interviewers on ethical issues, on many other aspects, as well as interviewing these sensitive issues. And we separated male and female PSUs so that there is no ethical issues in asking or having problems asking these kind of questions. So we did a lot of things to actually so that we don't get an underreporting on this. Still, you cannot always guarantee underreporting. This is in 2012. You can just show, instead of showing both years, I just showed 1 year, where boys and girls have same age, almost same schooling, very similar schooling. The differences were a little bit in the religious affiliation and in urban-rural residents. Otherwise, they're very, very similar. go to the findings on romantic relationship, magnitude, characteristics, and trends. This is what we found. About 8% in the first survey, about 20% of the boys in the second survey reported a romantic relationship, and that has also similarly increased for girls. So the huge increase in reporting of romantic relationship over the years 2007 2012, and the gender and rural urban disparities are actually narrow in both the times. There are some characteristics show age at the first date, with the percentage who had first date before or on or before age 15 increased from 45 to 57% for boys and 47 to 63% for girls over the years. So they are actually making the relationship earlier than before. More boys than girls report their partners of same age. Girls generally reported their partners are of older than them. The boys reported almost same age in about 50% cases. This is the result of the physical intimacy in romantic relationships, and you can see that among those who had a romantic partner, they were only those are asked these questions. For boys, the increase in physical intimacy reported in 2 rounds small. There's not much of change. But for girls, there is a substantial increase in reporting, and that because of that, the gender differences that we found in 2007 narrowed significantly in 2012. If you see the graph very closely, you can see the transition from one stage of intimacy to another has also flattened a bit. The steepness that has gone almost. You can see earlier for girls 64 to 16 is the steepness, now 77 to 41. So it's becoming flattened. So those who are having one experience are likely to report other experiences as well. So far I've been talking about the sex that I have been talking about is with the romantic partner, but we had, as I told you earlier, a range of questions on other partners as well. So here I'm talking about the overall sexual experiences for all the respondents in the base. This is in 2012 about 16% boys and 11% girls reported having sex. This 15 to 19 years old girls. You can see it was 6% and 2% in 2007. So there's a huge increase in reporting again. In overall sexual experiences, 6 to 16% among boys and 2 to 9% among 2 to 11% among girls. Sorry. More rural than urban adolescents reported sexual relations, contrary to the belief that it is only happening in urban areas, not in rural areas. These are the types of sexual partners they reported to us. Most of the sex that is being reported with romantic partners, like 10.5 out of 15.6 is with opposite sex romantic partner. A lot of forced sex reported also among them. You can see 5% of boys reported in 2007 compared to 0.2% in 2007. In 2012 they are reporting much higher than 2007. Probably because we gave them an opportunity to report it anonymously in forced sex. In 2007, we did not ask the forced sex question in anonymous format, but in 2012, we added that question in anonymous format, and that showed a huge increase in reporting. Even for the girls, it was only 0.2% in 2007 reporting that somebody forced sex on them, while in 6.1% in 2012. Yeah, thank you. Nature of sexual experiences have become riskier. You can see that they have the earlier sexual initiations. 4% reported earlier, less than 18 when they first had sex. Now 21% boys and 17% girls reported so. Then 2 or more partners have huge increases in multiple partners to 22%. And 0 to 10% among girls. Consistent condom use actually has not changed much. It's about 21% for boys, and girls it actually shows a little bit of decline. I'll skip this one. So what is the way forward? To retaliate the adolescence as a dynamic group, and in this rapidly globalizing world, this extent and the nature of the premarital relationships have changed considerably over just 5 years. And what is we think what is being observed now in Rajasthan, where we did the survey, probably likely to be true in other states as well. So we need to monitor time to time and anticipate changes. We have a new policy program, RKSK, they say, for the adolescent girls and boys, and so they should take note of these findings and program accordingly. Thank you.
Thank you very much. I'm sure there'll be very many questions on that particular one, so we'll be very interested. Our next and final speaker is Dr. Jamil Zamir, who is a program specialist in the area of access to sexual and reproductive health services at the International Planned Parenthood Federation office in South Asia. He's also a member of the steering committee of Men Engage Alliance in South Asia. Welcome, Jamil.
Thank you. Thank you, sir. Excellent presentation on work on policy work in Brazil to romantic relationship, and coming to the integration of working with boys and men within the federation. And I thought, let me begin with the story. And it is started in Nepal when the Men Engage South Asia started, and we had a meeting, and then that's how all these stakeholders came together, and that was that's a group photograph at the end of very extensive discussion on how to work with boys and men. So it was in 2007. My presentation is primarily structured in terms of giving a little bit background of the institution, and then moving into how we have integrated this work and some photographs from the field. IPPF is a global service provider and a leading advocate for sexual and reproductive health and rights for all, and we work in 152 countries with communities and individuals. If we look at the IPPF background, and I thought I should highlight this point because how we have integrated this work will kind of set a context. We are traditionally a family planning and reproductive health provider. Most of our clients are female. Our work is rooted in feminist and women's rights movement. We are member of Men Engage, both at South Asian International Forum and with SANAM, which is the South Asian Network to Address Masculinities. The work with boys and men started with the policy in 2008 with the boys, IPPF giving a very clear, stated policy how we need to work with boys and men, and then recently a gender equality policy. There are a number of efforts being made to integrate, a number of tools were developed. I will not go into it, but I think quickly just running into in the terms of family planning, what we have seen in the beginning with contraception, that it's for women, then it gradually moved from women to men, and then we started looking at the supportive role of women, and we started looking at men as agencies of change, and now we have really expanded the full engagement in terms of men's sexual rights, which is looking at men's own need. In brief, this is what the IPPF policy is, and the person who initiated is among us, Tim Shand, who was the one who started this work, and we have tried to see comprehensively how we engage men at different levels and at different stages, both boys and men. And there are broad themes. I'll not go into these, it's quite explicit, but it just shows the kind of comprehensive nature of the policy. So the first step for the region was to actually set a baseline and find out where things are in terms of starting our work. So we did this research in 2008, which has helped us to shape our programming. This report is available in our stall, and I'll just go 1 or 2 slides on this. So, just like any other studies, this research also confirms that a positive relationship between the equitable man with the increase in family planning methods, decrease in interpartner violence, healthier attitudes towards women and masculinity, and in a way helped our member associations in the region to take this forward with their governing board. Again, quite a similar finding that we have seen in other researches as well. But I think the important point, particularly effective condom use prevents pregnancy. They all believe yes when it comes to condom reduce sexual pleasure, and I think there's again this area which requires further discussion around working on that. But I think the concerning area is male sterilization reduces sexual pleasure, very high percentage, and there are myths surrounding it. So really we need a strong communication around this area. These were the needs that were expressed by the respondents, and we know about these expressed anxieties, and the first one primarily looks at the counseling components, whereas the other 2 functionality related problems and symptoms are both counseling and the clinical intervention. And this really helped to identify how things are actually expressed from the respondent's perspective and how a provider has to respond with that, because it's a very different language between the client and the provider when it comes to men's sexual health and also for women's sexual health. So when we started our work, we just looked at our broad program and we realized that the best way to go forward is to relook at our programming. So we were having a lot of activities around community mobilization, groups were formed, youth groups, women's group, and a lot of men who were there in those localities, they were keen to form and work. So the men's groups were formed, there's greater interaction between men's and women's group. There were women's empowerment program, and we have people like Dr. Maghfira and Heli here who started this work in Bangladesh, where they have this microcredit program, and women really ask them, why don't you engage men? Because while the economic conditions improve, but the violence levels remain the same. And so they invited them, a simple involvement, and then it became a very intensive involvement, and then they requested also for the services. So they have this family development centers in Bangladesh, 72, and now both men and women are there and taking benefit of that. Likewise in Pakistan with the microcredit program of Khoshali Bank, they tied up a similar design where women requested, and why don't you involve them, and we have seen a same perceptible decline in the interpersonal violence. And then the clinic started. Our experience with the clinic was that we initially started with these evening clinics because there was a strong demand that we need separate clinics. So there is still clinics which are exclusively for men, but then there are clinics which are for both, and we are trying to see how we can bring in men into this service delivery point, make it male friendly as well. Outreach sessions worked quite well, and these are especially organized in the male spaces where they are comfortable to come and seek services, social marketing, research, and so the message from here is that we have not brought a separate program altogether and said we'll now work with men. It was the program which was relooked at, and we see which are the entry points to start working with boys and men. I just thought to share with you this kind of service delivery model that we have. So you'll find that service delivery model has integrated madrasa health post. These are these are Islamic schools where there are young boys and girls. There are mix also, but there are exclusive boys madrasas and girls madrasas. So we started working in madrasas, then our family development centers, schools, community structures, and we have linked it with the government structures as well. And then there is this youth helpline, and there are community groups around. So this was the model, which was further strengthened with engaging boys and men. We also developed this tool. This is again available in this stall. Is a very simple pamphlet which looks at unpacking of masculinity and goes into different sections about sex, relationships, sexual myths, where to go, what kind of services. This is from Sri Lanka, so we have a range of services offered through this clinic. I'll not go into the services offered. Now these are some of the photographs from the region. Group education session. This is from Maldives, working with young boys and girls. They have this sexual health exhibition in Sri Lanka, it's a mobile sexual health exhibition which they organize periodically at different places, and then they have counseling sessions also along with it and services. This is work with madrasas that we are doing in Bangladesh. Again, these are sessions, whether we call it health education, but it's also become more of a couple counseling if you go deep into a lot of issues. Maldives. The work with Pakistan, with the religious leaders, with lot of work around Friday sermons, which they talk about violence and other health issues. This is from Bhutan, and they have shelter homes, and they are engaging men intensively in this work. So, in terms of services, this is the trend that we have seen, that we, after organizing the program, and we have seen a shift with this trend of from 2011, and we have now served 2.8 million male clients in 2013, and this trend is going, and it almost constitutes about 26% of the total clients. Any question? These are just few points around it, and not included a lot of points here, but the first one is really to recognize, and we realize that it's very important that we recognize the challenge for a man to come out of this man in a box, and how to move out of the box, how difficult it is. And I think that process takes time. So the initial process was extremely difficult when we started engaging, though there was women who are keen that men should come. So once that process begins, there's a kind of a group dynamics where then they all start coming and engaging. We have seen that it's very cost effective, and and also from the gender perspective, that because we have a strong women's program and youth program, and integrating men make it quite comprehensive, and in a real way looking at the gender perspective around that. There's some change, I would say, in terms of female specific spaces, to one extent equally by couples and unmarried. We're still working on this area, and I think this area requires a lot of time, and we need to have some parallel strategies of exclusive sessions and exclusive clinics. So I'll end with this. Thank you.
Thank you very much. Thanks, Jamil, for sharing your work and the work that the region is doing to ensure that men and boys' sexual health is integrated in your services. So what remains is for us to ask them all the questions that are burning. We will take a few, and then they'll respond, and if there are more, we'll take some more. Questions, comments? Yes? Emma, then you. Yeah.
I'm Beno de Kaiser from Mexico, and I have a question and maybe a discussion that would be interesting to open it to a wider public. Brazil is one of the 3 or 4 countries that has a specific male program, general men's health program. In Mexico, about 12 years ago, the Ministry of Health started a women's health program that evolved to the National Center for Gender Equity and Health. It's more reproductive health. So the question is, I make myself is, what would be the best tendency to have separate programs dealing from a gender perspective for men and a small program, but growing program that will be conflicted in budget needs when it grows, or the tendency should be like a gender perspective program that attends both needs and is aware of imbalances. For instance, girls are in Mexico and many countries are very earlier in consuming drugs and alcohol, or the feminization of HIV in our countries. It's more a male epidemic, but it's feminizing, and people on HIV are not aware of this. What would your perspective be on the long term?
Okay, thank you very much. We have another one.
My question is to this Brazilian presentation. That I saw there are a lot of policies we have developed in our country. And it's alarming that a lot of percentage of males, they are going to suicide. And I want to know that do you have any study to see why the males are going to suicide early? What are the causes behind it? And have you country taken some strategy or any policy to prevent this type of suicidal tendency, or to prevent this type of early suicide?
Okay.
Yes, I found that this is a very interesting program in India. I just want to know, you don't find any difficulties in terms of men utilizing the space to talk about the men's health? Because as where I come from, I'm from South Africa, Cape Town. In our men's health clinic, we find that men are it's very difficult for them to take part because of the stigma, and they won't be known by the community, like who came for test of HIV, whatever, who came for, and then now find it very difficult, the stigma. We don't find those problems in India.
Okay, let's take last one, and then we'll take another round.
Thank you, those were great presentations. I guess my question is largely for Daniel. Just thinking around the incentives that you use, or if any, to try and get men to come to health services. I'm currently based in Malawi, and one of the things that the Malawian government has tried, for example, is saying to women who are in the long queues for antenatal care, if you bring your partner, you'll be seen quicker. I know there are issues around kind of, why should women who don't bring their partner still have to wait in a very long queue? But nevertheless, they're thinking through these kind of strategies, because men say, I don't have time to wait for hours in a health centre, I'm busy, I need to work and put food on the table. And I guess Brazil, given the levels of poverty you also have, deal with many of those issues. So how do you make it worth men's time to come, and what are the incentives that you've been thinking about?
Okay, I think that's Fabio. Just a second. Do you have an additional question? No. Okay, I'll take the last one. I know I said the last one was the last, but let's have this one.
Yeah, the money from Namibia. The men's policy in Brazil. How much support and or resistance from the political structure it was encountered in putting that together? I'm very much interested in the strategies used to lobby, promote that, especially from political leaders.
Okay, thank you. So let's have responses from Jamil going that way. There's some specific ones, so please respond to them.
So the question related to men seeking health services in India. Let me begin with an example from Nepal, and I'll come to India. Non-scalpel vasectomies are actually conducted by female doctors. So in India also there are places where males are quite comfortable, but there are places where there is strong resistance. And it's it's extremely difficult because there's a lot of community pressure. And so at some places they have made separate waiting areas for men. So the response to this particular question is that I think it requires a lot of discussion within the community, awareness about services, and the availability of quality services. Often the quality services part is missing. So if we can emphasize on the quality of services doctors can provide, the possibility that and we have seen it in some of the clinics that the male client seeking services goes high. But still it remains a challenge. It's still, I mean, it's not that once you do all this, man will start seeking services.
Okay. Daniel?
Okay. I'm going to start from the last question. It's quite interesting because the thing is, it wasn't hard to implement the policy. There was no need for a lot of lobby, for mobilization, or anything like that. Especially because there basically is almost no public mobilization in Brazil for men's health. So it's totally different when you talk about women's group or adolescents group or something, or LGBT movement. There's no movement in Brazil to increase men's health. So it was not like men went to the street saying that we need health, and that never happened. Or groups of men did not go to the Brazilian parliament to demand that they had their health needs met. No, that never happened. So basically it was something that the Ministry of Health realized that it was necessary, and the policy started to be elaborated as a technical issue and not as a political issue. So it was written down as a technical piece. We need this to improve the health of men and to improve the health of women and the whole population. So, but it really helped. I think that if we had a lobby, the lobby that happened actually was from the medical associations, that sometimes we have a lot of difficulty dealing with them, because the lobby, for example, to have more urologists, doctors inside the system, because they think the men's doctor is the urologist, and we say no. That's the doctor who's going to take care, especially of things related to what the urologists do. Men's doctor is the family doctor, is the general doctor, but they do a huge lobby in Brazil to try and get more urologists inside the system. So in a way, their lobby sort of was positive during that moment, because it allowed the policy to be implemented. It helped the policy to be implemented. And it was good that they were not there writing the policy by themselves. Promundo was there, Papai was there, different NGOs and different academic institutions were there also writing down the policy. So, but that was basically the only lobby that was done by the medical institutions, because if more men go to the system, then they'll sell more drugs, then they'll have more doctors, specialized doctors working, and that's not the way that we want to go about the policy. We do not want to over-medicalize men like it was done to women traditionally. We do not want to control men's sexuality like it was done traditionally to women, and it's still done to women. So we want to really use gender perspective in a way to see that our biggest problem, the biggest problem that involves men's health, is not the lack of doctors or the lack of hospitals or the lack of drugs, is machismo, is gender stereotypes, is sexism. That's the biggest issue around men's health. Not drugs, not specialized equipment, not doctors. So we have the hospitals in Brazil. We need more hospitals, we need more clinics, but they are there. We do not need a specific clinic to men. We just need those professionals to realize that men have health needs and rights, and to get those men inside the system. But the system is there, the institution is there, the clinics are there already. We just need to get men inside to be able to invite men, and that's when we get to the other question. How do we do that? So first, one thing that we're trying to do is to get a night shift inside most of the family health clinics, not to men and women. But by doing that, because lots of men say, I do not have time. I have to work full time, so I do not have time to take care of my health, to go to the doctors, to be in the huge queues, to get inside and this and that. So we're trying to get these family health clinics working on Saturdays, opening up during the night shifts also, and that helps men to get inside. But at the same time, that doesn't do all the work, because most of these men, some of these men that say that they do not have time at all to go there because of the queues, sometimes these are the same men who are going to be in a queue during the week on working hours for 6 hours to get a ticket to go to the football game during the weekend. So they prioritize the football game. They do not prioritize their health. So that's why we have to do a lot of work to sensitize men to show that health cares. I mean, health is important. Health is a main issue. So this is like our main pamphlet for the policy, and we're saying that it doesn't matter the type of man that you are. You can be, you're black, you're white, you're gay, you're heterosexual, you're tall, you're fat, you're skinny, whatever. You're working man, you're not working. It doesn't matter. But be a type of man that takes care of your health. So that's the message that we're trying to put out there. Health matters. So we have to sensitize men and to show that by doing that, they'll live a longer life, a healthier life. They'll have more psychological and physical well-being, and they'll be happier. They'll be happier with their partners and children and all that. So that's what we're trying to do. Relating to suicide, it's really interesting and sad, despite the numbers, despite the 92% of homicide among men, despite the number of 78% of suicide among men, there are very few studies, especially with suicide being done in Brazil, and trying to figure out what happens, what is going on with men. How can we reach those men? How can we get those men to talk? How can we get those men to go to the mental health facilities that we have in the country to try and do something about the situation before it actually happens? Because women try to commit suicide more than men. The number of women that try to commit suicide is a lot higher than the number of men. But actually men, when they do try to commit suicide, the ways that they try, they're sure of it. So they use a gun, and they take a shot to the head. They jump from a 15-story building. They jump in front of a car or something. So it's done. And women usually in Brazil take more poison, drugs, try to turn the gas on the stove or something like that. So things that they cut their wrists. So things that usually you can they can be saved if someone comes or something happens. So women give signs. They talk about the situation, and men usually hold on to the situation. Sometimes these men kill themselves, and I've heard statements from families. You have their partners, their mothers, their fathers, the priest from the community, the doctor from the health facility, and the employer, and they say, that guy never said anything. He never said he had a problem. He never came to anyone and saying, oh, I have this huge problem. So imagine the situation. This person had the courage to get a gun, put it to his hand, and blow his brains out. But he never had the courage to talk to his partner and say, look, I'm hurting. There's something really wrong going on. So and that has everything to do with gender relations and gender stereotypes and the way that we are brought up as men, that we have to be tough, that we cannot say that if we talk about emotions, that means that we are weak somehow. So no, we have to do so much more about that. And then a really interesting question. I think everything will meet somehow at the end. I mean, and I think there will come a time that maybe we won't need all those little boxes inside the Ministry of Health, women's health, men's health, health for the elderly, health for the adolescents, and this and that. But of course, when we, especially at the beginning, when we need to bring attention to an issue that is not an issue, because men's health is not an issue. So I think right now the policy is really needed as an educational policy. I think most of what we do is educational. It's more than just the regular health activities. It's more we're educating people. We're talking just to be talking about the issue, this issue, to be doing campaigns. So people are like, well, I had never thought about that. So we're talking to doctors, and they're like, can you believe they had never, ever thought about men's health? They just didn't come. And I was like, okay, I have nothing to do with that. I deal with people who are here. If they're not coming to the clinic, it's not my problem. Why is it my problem? So just to be doing campaigns on that and sensitizing the doctors and nurses and psychologists and the social workers to say this matters. And it is your job to also walk around the community and try to see where these men are. We have community health agents in Brazil. We have thousands and thousands of them. It's sort of like the model that was instituted, I think, first in Cuba, especially. If people do not come to the health facility, these people go to their houses and do house visits. So what happened in Brazil traditionally is that these health agents, they would knock on the door, and the guy who answered was João, was the father of the family. And so they were like, is Maria home? And was like, no, she's not home. Are your kids home? No, they're at school. Okay, I'll come back later. And they would go away. They would not talk to men. They would not talk to the men by themselves, because it's like, okay, my job is to talk to women and children. You don't matter. I have nothing to do with it. So and this happens all over the country. So there's so much work to be done. But I think at the end we will meet together, and most of the things that we're doing right now is in partnership with the women's health, is in partnership with children's health. So most of the campaigns that we do are done with them. Everything is talked at all times. So I think that we're sort of doing that already, but I think that we still need those little boxes. Women still need the boxes. Men still need these boxes. The elderly still need those boxes to bring attention to the issues. But I think that maybe, I don't know, 15, 20 years, I don't know, we won't need them anymore.
Okay. No response. Okay. We have,
I had a question just for Rajiv.
Yeah.
I didn't. I maybe you said it and I didn't understood it. I wanted to know if during the questionnaire, if you asked men if they had suffered a sexual violence, or if that was a question that you only asked to women.
No, we did ask. Sorry, can I respond? We did ask both ways.
Okay.
Yeah, but the reporting is very small. I mean, it's
Okay.
less than.
It's like zero all the
It's
time.
almost like zero.
And you have
Because
any
we
take on that? You think that was the truth, or do you think that many men actually have had experiences of suffering sexual violence in your contact?
I guess there are, but it's a reporting issue. They just don't report.
Yeah.
And in the anonymous format, the question was about the perpetration, not about the experience for men. And
that's
if we had used it for
Yes.
that way, probably we would have got.
Yes, I think that was the opportunity. Yeah.
Next time.
okay, there are some burning questions. We have very limited time, so keep them very short and keep your responses short.
Yes.
Okay? Okay, one.
I guess this goes for Daniel and maybe the other two panelists. In your research that you did you find differences with the indigenous communities of your nations? Was there a variety with the health-seeking behaviors of indigenous men? When you were asking your questions, was it mainly formal healthcare? Because you usually have indigenous healers as well that are often accessed. So did these questions cover health-seeking behaviors to indigenous doctors and so forth?
Okay, there's another question. Here, and then you have two more.
Okay, this is for Rajiv. Rajiv, it's a very interesting study that you have conducted. You have done the follow-up of the same areas where you did the study in 2007 in Rajasthan. And the findings were very alarming. There is a significant behavior change among the adolescents. Couple of questions related to the methodology. One, that in what settings these interviews were conducted, at home, and if at home, then how this the privacy and confidentiality was maintained. Because normally in Indian settings, when interviews are conducted in the family, all family members are around. So there is one question. The other is you have also asked anonymous response and also face-to-face response. What was the agreement between these two responses? And last is that have you also tried to understand that what has changed in these 5 years in the environment within the family or in the community that might have contributed to this type of a change.
Okay, and the last question.
So I kind of sort of have two questions for Rajiv. It's just very quick. Just for the questionnaires themselves, if you used others as basis, the WHO multi-country or the DH, there's many studies about intimate partner violence that exist. I'm just curious if you used similar questions that would be comparable. And Danielle, I'm sure Eduardo might have mentioned this in the other study, but I was curious, you mentioned that the unit works together with others. So I'm curious, how does the Men's Health Unit work with the program, work with the adolescent program in terms of engaging male fathers, right? So we know there's a lot of difficulties with teen fathers being engaged, a lot of barriers. I'm wondering if there's any linkage between the Men's Health Project and the under 20 fathers.
Quick responses, so we're not thrown out.
Thank you for your questions. Yeah, I mean, privacy is an issue. For most of the cases, for boys it was not that a big issue because boys can be taken out of the house and can find a private place where they can talk. For girls, yes, it is an issue. So what we did, we actually always given our interviewer an option of calling somebody else to, kind of distract other people. So if she thinks that, girl, you cannot take the girl out of the house, of course, and I cannot do it in a private setting, then she calls a team supervisor, and another additional interviewer is sent to her, and that interviewer will engage all other family members or others in a discussion so that this interview can be done in private. This is very expensive sometimes, it's very time consuming, number of interviews goes down per day, but this is how you have to do it. And we have been doing it for many other studies too. There were disagreements between anonymous, of course. As for example, forced sex was only 3% reported in face-to-face in 2012. When we asked in anonymous format, it increased to 7% for boys and 9% for girls. So there are huge disagreements on these two things. But but as you see, I mean, you can say that those who had said yes in face-to-face, there are not many who have said no in the anonymous. But
you will not have that any way to, cross verify the responses given in the anonymous.
No, because we put a code. It's not. His name is not there, but we have a code on the envelope, and we can connect that response to the individual respondent. That's possible.
Okay, let's have
the last question there.
The whole. It's not about sex only. The whole. There are many other transitions that we said. Their knowledge has increased, but they have other. The access to internet increased, the access to mobile phone increased, the education level increased. A lot of positive changes happen, but some negative changes also happen. We need to do more to understand those changes.
Okay.
We did use IPV for the married, the IPV questions are WHO or the DHS questions. For the unmarried, the sexual violence questions are something that we had tested before in our 2007 survey and repeated here to be compared.
Okay, thank you, and Daniel.
Okay, Tura, I think at first the policy, since it's a really new policy, most of its efforts were drawn to men in general, adult men in general. And now I think since since last year we've started to target specific male populations. So we've been doing a lot of meetings with groups of indigenous men, with groups of gypsy men. There are a lot of them also in Brazil, and with groups of gay men, bisexual men, transgender and transsexual men, also to see what are their health needs and what would they like to see inside this policy towards them. So I think that we're just starting to get those meetings going and to listen and to see what exactly to learn from them what are those their specific health needs. So, but we're still a long way from being there. Fabio, some of these little boxes inside the ministry, we get along and really easy with some of them, and for some, there's still way too much to be done. And with the adolescents, I think there's still much more dialogue to happen. It should be something that it shouldn't be happening, but that's the reality that we have right now. So of course there is a dialogue, but not as much, not even close as much as there should be. So some of our material in this, for example, it talks a little bit about adolescents, saying that fathers should be involved, especially adolescent fathers should be involved. They should be there also during birth with their partners, not only the adult men, but also adolescent men. But there's still much dialogue to happen between the two coordinations. Yeah. Just to be clear.
Okay, let us really give them a massive clap. Thank you very much, everybody.
Thank you.
Thank you.